to UKIO 2023. My name is Namanjul Anderson and I'm joined by fellow host Joe McNamara.
Hi everyone!
So we've got two new guests for you to listen to. Do you want to introduce yourself?
My name is Hollie Thomas. I am a senior stereotactic radiographer from Sheffield.
Hi, my name is Nancy Figueroa, just to put a bit shorter, and as well I'm a senior therapeutic radiographer at the stereotactic.
So, I know you both quite well.
You do.
So, how do I know you? Do you want to both talk a little bit about maybe your career pathway?
Well, we go all the way back to 2009.
Is it 2009?
It's 2000.
That makes me feel really old.
2009.
I wasn't even a radiographer. I hadn't even thought about that.
So now I feel
I
really
was
old.
16.
Oh my good God. So yeah, 2009, you interviewed me as part of the trainee assistant practitioner role. So, and you were one of the people that gave me my job and kick-started my career. And then it's just whirlwinded all the way from there. So.
Can I ask? So, obviously now you work in stereotactic radiosurgery. It's a very niche, specific area of radiation treatment.
Yeah.
What made you progress into that field?
I found the theory behind it so interesting.
Right.
So interesting. And when I always say to when we have students come to us, when you look at the grand scheme of medicine, radiosurgery, it's still developing, it's still quite new, and it's still advancing, and it is advancing every single year. And I find that so interesting because it is such a sidestep from radiotherapy. It's so specific on the brain as well.
Yeah.
That has so many different avenues and ways that you can research and look into, and I just find it so interesting, and I never bore of it.
Yeah.
And I thought, well, if I want to do something in the job that I'm going to do every day, I want to do something that I enjoy. And so I went down that route.
Perfect. And Nancy, your career pathway was a little bit different as well. Do you want to share kind of how you got into being a therapeutic radiographer?
Yeah, so basically I did have some previous studies in something completely different. I come from the background of biomedical engineering, but I was just kind of missing to be more with patients involved and stuff like that, along with technology.
Yeah.
So I found this degree that you can study to become a therapeutic radiographer. At the moment when I read the description and everything, I was like, right, this is the right profession for me. So I went into it, and I just retrained in 2018, finished in 2020, and then I ended up working in a whole different radiotherapy sites, treating all different parts of the body. But when I was studying, I just have a little bit of placement at the stereotactic radiosurgery, and I really like the team there. Yeah. And as well, yeah, no.
Have you got to say that because
it is true. And I just like how they can become a bit more specialized in doing like clarking, like checking cranial nerves on people before treatment, or doing some clinics. Anyway, so at some point I saw a vacancy and I applied for it and I got it.
No.
And I'm just a happy bee in this placement, which our manager is very good.
Yeah.
Wing wing.
Are you trying to get extra annual leave?
No, but she actually is the boss. You know, if you want to study something more, you know, and stuff like that, to give us like time to study and whatever. So no, I know, but I had to say it. She's a very good manager. So she just keeps us happy, and she was the one who actually looked for funding for us to come here. We got a little poster, you know, from your idea, Joe. Do you remember when Hollie went to Western Park and saw a little poster and said, why don't you apply it for the UKIO? And that's why we're
here. You are.
Yeah, so
I love it when my ex-students listen to me, because you didn't when you were students.
It's funny though, you've probably trained half of the workforce at the moment.
It's true.
That's 2% of the workforce.
It's true.
What's the best part of the job for you?
The patients. Having that one-to-one with our patients, because we, like radiotherapy, you see 50, 60 patients a day on a single linac. We can only treat a maximum of 4 patients a day, and you are one-to-one care with that patient. So from the minute that they arrive in the department to the minute that you discharge them home, you are with them and you are advocating for them throughout the day, and you're caring for them, and everything that they need, you are their point of call. and you get this such sense of achievement and pride in what you do.
Yeah.
And it's just so lovely that at the end of the day, like the nicest thing that a patient's ever said to me, and it just makes me well up sometimes. It's just like, thank you for giving me the gift of time.
Yeah.
And it's like, I know that that's actually come from the bottom of their heart, and we have given them that. And it's just, it's having that one-to-one and the connection with the patient that's, for me anyway.
Yeah, for me it's because I'm quite interested in research and service development and stuff like that. So going back to the site, that they are very open for us to explore those venues, the support and everything. So I'm little by little getting into, I kind of support the journal club in the department and stuff like that. So, it's nice as well to develop that other side of like things that I like, as well as patients, of course. I love my patients.
So, obviously being at UKIO, from a stereotactic radiosurgery perspective, as therapeutic radiographers, you work really closely, don't you, with a large multidisciplinary team, but specifically radiologists and diagnostic radiographers.
We do.
So can you just maybe share for maybe people within the diagnostic radiography field who don't know what radiosurgery is, can you maybe give us a bit of insight into what you actually do? What does your day look like? What does the patient have to go through?
Yeah, so we are trained therapeutic radiographers, but like you say, our role is so far from that, from our training. So we can only treat lesions within the brain, and we treat benign, malignant, functional and vascular. And what that means is that the patients will come to us, and for us to be able to localise what we're wanting to treat within the head, we obviously need imaging, and that comes on different platforms. We've got CT, we have MRI, and we have angiography as well, which is obviously completely out of our remit. That's all diagnostic. So from our point of view, we will fit a stereotactic frame onto the patient's head. We then hand over to the MDT, either the MRI radiographers, the angiography team or the CT, or a combination of all of that. And it's from utilising the diagnostic side of the radiography service that we can plan and do everything that we need to be able to do therapeutically for that patient as well.
Perfect. And from a patient's perspective, we've had Chris Helenga come on to talk about stereotactic radiosurgery. At what point do patients come for radiosurgery? Because there is metastatic brain metastases where you may potentially have whole brain radiotherapy versus radiosurgery. So could you maybe talk to us about that, and from a patient's perspective, at what point would they be a whole brain radiotherapy patient versus radiosurgery?
So there is limitations on what we can do. It tends to be more to do with volume than it does with the amount of lesions. There is a criteria in which they have to meet, which is set by NHS England. But basically, the way that it's moving now is that the whole brain radiotherapy used to be the first point of call when it came to metastatic disease within the brain. That has side shifted, and that's changed now due to research and developments and everything. They're now looking more at radiosurgery being the first point of call, depending on the widespread disease and whether it is controlled.
Right.
If a patient was to come to us with 20 lesions, I would say that we can do that. It depends on the volume and the critical structures in which they are around. If a patient was to come to us with uncontrolled systemic disease, we wouldn't be able to do that because it wouldn't be beneficial for them. It's all patient dependent on their own circumstances really, as to what we can treat or not. So the success rate is really, really good.
What are you hoping to get out of UKIO?
Well, that's what we have been looking at the program this morning. So we are thinking divide and conquer. So we're going to divide. Some of them will go Hollie, some of them I will go. And then we are coming back, hopefully to do a little presentation to our department about our takes of it. Which I hope it's not that challenging. I hope we manage it right. But yeah, basically just try to get as much information. Maybe if it's to do with workforce, like how do we, get them keeping there, motivation or whatever. And so just to see every topic really, what could it be beneficial for our department.
Nancy created a really, really good poster that's basically how to become a therapeutic radiographer within stereotactic radiosurgery, because we are quite a a niche market. So you've done a really good poster on that.
Yes.
Which we're going to go find because we've not found it yet, so we need to go do
Perfect.
that. So yeah, we are going to split our
If you
time.
send us a link, we can link it.
There you go. There you go. She'll be on that.
Perfect.
Thank you.
And can I just ask, just purely in terms of kind of your roles as therapeutic radiographers, where's your scope of practice? Because obviously within radiotherapy, you have trajectory to do enhanced, advanced, consultancy. What does the career pathway look like in stereo radiosurgery?
So you would come in as, there used to be only standard band 6s, that's where you used to go in at, but now they've reduced that and changed the role very slightly, so you would go in as a band 5, and then to be able to progress you would do radiographer clinics, so we would see the patient the day before and you would coach them through what was going to happen. We've also started, there's quite a few of us that have done the APAX training. So we can now call out
Which
patients.
sounds easy, doesn't it, the APAX training? But that in
Really,
itself
actually,
is actually like, it's like a PhD.
It is the hardest thing I've ever done in my entire life, and I'm not exaggerating when I say it broke me. It actually broke me. It was so
but when you do it
difficult.
whilst also pregnant and having babies.
I was on maternity leave when I started it. It wasn't my finest hour with baby brain on top of everything else. It was it was really difficult and definitely the hardest thing I've ever done. Even compared, I would say my full MSc was easier than that module alone.
Yeah.
It was difficult, but it also allows us to cut out the middleman. We now don't need to rely on other people to do our job for us, basically, because we can do it ourselves. So we are, although it doesn't fall within advanced practice for us, which is a shame because it should. It doesn't, and we're now going into, we've got a couple of radiographers that are now doing their non-medical prescribing. They're halfway through that as well, so
That's a hard course as well.
Yeah.
As Norman will testify.
yeah, they're doing that at the minute. They're just waiting on their last result, I think. So, but yeah, they've said that's pretty hardcore. So yeah, there are avenues to be able to progress and do more.
Yeah. Do you have consultant therapeutic radiographers within radiosurgery yet?
No.
And I say yet.
Yet we should,
Yeah.
absolutely we should, and that's where it should be going, and we should be pushing for, and hopefully we will get it because it should do it. The role of the radiographer in radiosurgery is very undervalued, and it deserves a lot more recognition than what it gets.
You've got a lot of competition with some neurosurgeons, though, haven't you?
Yeah, I think that's half of the battle. Definitely. Definitely.
Well, a big shout out to the Sheffield Gamma Knife radiosurgery team. It's great to have you on, and thank you so much for joining us.
Thanks for having us.